These are not going to be much for times of time. Maybe I've definitely gone fellowships. I want to make sure. I just haven't heard you guys just I used to do Kaiser, and I think I should have like, are they getting anything in a container? No, they still have it. It's just not, but because I was on Kaiser at National Tour, so I just, when I first moved here,
Good morning, guys. Welcome to Rheum Renal.
I'm a poor substitute for Josh Thurman. He's still on sabbatical. We'll be back here at the beginning of May. But I'm Jamie Dulesky, one of the nephrology attendings who mainly works at Denver Health with Dr. Davis.
Yep.
So
Denver Health strong today.
Yeah, well represented. So thank you for all attending. Hopefully it's a stimulating case. And hope that we continue to work together both on clinical trials and all that. Certainly, Dr. Podol is the lead person, but if you guys have anybody who has a shared rheum renal condition, please reach out to me and I'm sure we can find something to help patients.
And we'll ask admin to, again, circulate any of the trials that are ongoing, just so we can all keep that in the forefront of our brains. So we'll each reach out to our admins to send it to all of us, so we can be well informed. All right. In light of that, we're going to turn it over.
All right. All right. Good morning, everybody. My name is Julia. I'm one of the second-year fellows.
And I'm Marco. I'm also one of the second-year fellows.
You guys might want to get closer to the microphone.
Nope.
Oh, okay, gotcha. And then can we just check that we can be heard on Zoom? We can hear you. Okay, wonderful. Thank you so much. All right, so let's go ahead and get started. So let's start off with the patient case, and actually I'm gonna maybe move so that we can see things. So for this patient case, we have a 32-year-old male. He has a history of Raynaud's and dysphagia, who presented initially to an outside hospital for daily nausea and vomiting for about a week. He was found to have an AKI at that outside hospital with a blood pressure into the 190s over 120s and hypertensive emergency, requiring a nicardipine drip and features concerning for autoimmune disease, for which he was transferred over to UC Health. And history of his Raynaud's, it began about 3 years ago when he was scraping some snow off his car. And 4 months of difficulty swallowing with food getting stuck in the middle of his chest. He has been self-medicating for severe GERD with a 20-pound weight loss. And then first noted skin tightening of his fingers 6 months to a year ago. And then he did describe some fatigue and some shortness of breath with exertion and cough. No relevant surgeries. He had a mother, sister, and a grandparent with lupus. And social history, he quit smoking 1 week prior to presentation, no alcohol or drug use, and the only medication he was on at home was the famotidine. And so looking at his physical exam, I'm so sorry. By the time he showed up to the university, his blood pressure was slightly better controlled, but he was still at 158 over 99, still tachycardic to 111, afebrile, saturating well on room air, and relevant findings of his physical exam. This is a picture of some fingertip ulcers that the patient had, and for the rheumatology note, there was some skin thickening and tightening of the digits, hands and forearms and face, and the worst was at the right second PIP area. And then with capillaroscopy examination, there was capillary dilation and occasional dropout. And then they did a modified Rodman skin score as well. That was 13. For your reference, anything above 20 is considered severe. The scale is on 0 to 51 being the max. It's just basically talks about how tight your skin is. And then for pulmonary, breath sounds were normal, and cardiac, regular rate and rhythm. GI was non-distended, non-tender. And so, oh my gosh, is there a way to just minimize this a little bit?
Sometimes it'll disappear when you
Okay.
compare over it.
When I just go over it here, I'll just do that. Okay, so looking at his labs, I would like a little bit of help perhaps from one of the other fellows or anybody that would like to contribute, just going through it and to highlight, starting with the BMP, I guess, what are we seeing here?
Or if someone would like to kind of explain their thought process or kind of give a small, brief summary of how the patient's presenting and kind of what you might be thinking at this point or how you might approach this patient?
Definitely most concerned for scleroderma renal crisis, especially in the setting of an AKI, hypertension, features of scleroderma.
Okay.
Also schistocytes and thrombocytopenia and anemia. So I'd be concerned for like a TMA of some sort.
Excellent. Yeah. So we have someone coming in with hypertension and they have an AKI. They have thrombocytopenia, they have anemia, and then we gave you the peripheral smear already, which says they have schistocytes, an LDH that's 523, and a haptoglobin that's low. And just like Matt said, he's concerned for maybe a microangiopathic hemolytic anemia or a TMA, and just like Jay said, concerning features for scleroderma and thinking about possible scleroderma renal crisis. All right, great.
All right, excellent, so moving on.
There's a chance there too.
I'm taking care of it. I asked everybody if they could hear the audience's responses. They're like, yes.
Okay.
And then this is the urinalysis on his admission. So we are seeing some protein with a urine protein creatinine ratio of 1. Sorry, these are just not going away. And then although it showed that there was blood in the urine, there are actually no red blood cells that were found and some microalbuminuria. But otherwise, for this case, rheum and renal were both consulted, and he was on that nicardipine drip on the outside hospital. Once his blood pressure got to gold, they ended up switching him over to captopril 25 milligrams TID. Okay.
That was kind of the initial patient presentation. What's next? So kind of, when we do these case conferences, we don't really like to approach things as lists really. So can someone come up with a differential diagnosis at this point? I think Matt and Jace kind of touched on some points, but how would you approach a patient who has AKI and thrombocytopenia? We mentioned TMA or MAHA, and kind of, are there things that fall under that branch that you want to consider on your differential? What labs do you want to get, things like that?
Anytime there's a TMA or MAHA, I want to make sure I'm ruling out the most dangerous things, so that would be like TTP.
Excellent. So, things that could cause or present with an AKI and thrombocytopenia would be a TMA, something like sepsis. There's infectious and hematologic causes for thrombocytopenia, pregnancy complications, and then obviously some autoimmune causes. And the labs we kind of already showed you, but these are mainly the labs that you would want to make the diagnosis of a microangiopathic hemolytic anemia. So this is kind of an approach when you have this diagnosis of TMA, and you could think about a TMA as either having a primary TMA or a secondary TMA. And just like Jay said, you want to rule out the stuff that'll probably kill the patient fastest, and you want to make sure you're not missing those. So under the primary branch of thrombotic microangiopathy, you have TTP, which is also known as Adams TS13 deficiency. And that can be either or acquired. And then you also have hemolytic uremic syndrome, which could either be from the Shiga toxin that's released in E. coli or atypical HUS. And now when we think of secondary causes, which is probably where our patient falls in here, you could see that there's a lot of things that could trigger a cascade that would lead to TMA and shearing of the red blood cells and schistocyte formation. So the secondary causes would be like a malignant hypertension, certain other infections, connective tissue diseases, certain cancers. There's a transplant-associated TMA, there's certain medications, and the last one down there is pregnancy with HELP syndrome and pregnancy complications. So
we can
we'll go back to our case now.
Yeah. So, given the concern for, possibly scleroderma renal crisis, possible TTP, patient did get a bit of an autoimmune workup, so his ANA was very high titer positive. The scleroderma panel did come back with a positive RNA polymerase 3, and he had negative extractable nuclear antigens for the in association with the ANA, and a negative ANCA as well. There was also, when we're talking about TTP, a negative Adams TS13 in this case, normal complements negative CCP and rheumatoid factor. Because of the concern for scleroderma, the patient also underwent a CT-ILD that showed no evidence of pulmonary fibrosis, but it did demonstrate like this patulous esophagus and trace bilateral pleural effusions, possibly in the setting of this malignant hypertension. And then his echo had a normal EF, some left ventricular hypertrophy, and a bit of RV enlargement, but a normal RVSP. And so, final diagnosis for this gentleman and what he was treated for was a new diagnosis of scleroderma with sclerodermal renal crisis and thrombotic microangiopathy. So just a word about scleroderma and systemic sclerosis. We generally classify it into two subtypes. There's the limited cutaneous systemic sclerosis versus diffuse, and typically our cutoff for limited cutaneous can be facial involvement. However, we typically characterize it as skin thickening involving the fingertips all the way up to the elbow, and involvement of the lower extremities of the toes anywhere up to the knees. If it's proximal to that, or if there's any involvement of the chest and the belly, typically we consider that diffuse. And these are some of the other cutaneous manifestations that you can see of scleroderma. Typically you have your classic Raynaud's symptoms with color changes that occur with stress or with cold. These can happen in the hands or the feet. Next to that, we have our nail capillaroscopy. Our view when we do a bedside nail capillaroscopy does not look this good, but this is just a general demonstration of some of the capillary dilation that you can see in early stages of the nail fold vessels. And then later on, when you have more severe disease, you can actually get tortuosity, loss of these like palisading architectures, and in general, just a big mess when you look at the nail fold capillaroscopy. Of course, we have the skin tightening. This is a patient that has pretty advanced disease where you have this waxy texture on the skin, but it can be much more subtle than this, especially at presentation or in early disease. And of course, we have digital ulcerations. And if you remember the patient's case, he did have some early digital ulcers that we presented the photograph for. Okay. All right, and then typically the Raynaud's itself is present in the vast majority of scleroderma patients, about 95%. And then talking about other systemic manifestations that we can ask about if we're concerned for scleroderma. I mean, of course, with renal, there's scleroderma renal crisis, musculoskeletal. You can also get inflammatory arthritis, myositis, acral osteolysis, where over time you can have actually loss of some of the bone on your fingertips or your toes. Tendon friction rubs, where you can feel kind of the opposition when you are moving tendinous areas. And then with pulmonary, you can get pulmonary hypertension and interstitial lung disease for cardiac congestive heart failure, arrhythmias, pericardial disease, and lots of GI involvement with GERD, esophageal dysmotility, GAVE, which is the gastroenteral vascular ectasia or the watermelon stomach, and then SIBO as well. And so this is just a look at, what we as the rheumatology team would be thinking about when we're diagnosing scleroderma. This is the joint ACR-EULAR criteria from 2013 that talks about, what makes up a diagnosis you would need, not diagnosis, but classification. It's not a diagnostic criteria. And so a total score of 9 is needed to classify somebody with scleroderma. And so if you have the presence of skin thickening in the hands and the fingers of both hands that extends proximal to your MCPs, that is already sufficient to make a diagnosis of scleroderma. But you can have skin thickening that does not, that does not go proximal. And if you have more subtle findings, it still gives you points. And if you have puffy fingers as well, We also mentioned these digital tip ulcers, telangiectasias also can be seen, abnormal meal-fold capillaries as a consequence of the Raynaud's, pulmonary hypertension and/or interstitial lung disease, Raynaud's, and then these scleroderma-specific antibodies, ACA being anti-centromere antibody. Okay. And then just some of the things we also like to think about in order to enter, even being considered by the classification criteria. Typically, you are also trying to rule out other causes of skin thickening because there's a lot of scleroderma mimics that we need to think about, such as, we may be familiar with the nephrogenic sclerosing fibrosis, scleroderma diabeticorum, scleromyxedema, GVHD, and among other things. And then skin thickening that spares the fingers is generally not something that we see in systemic sclerosis and can exclude a patient from this criteria. And then this is taken directly from Rheumatology Secrets, but this is just an overview of some of the antibodies that we associate with scleroderma, and not only their subset of whether this is limited or diffuse, but what their lung involvement is and what their kidney involvement is. So typically when we're talking about diffuse scleroderma, we're thinking about the fibrillarin antibody, the SCL70, or the RNA pol3 that we have in this case. And then scleroderma renal crisis is most often associated with any one of these three, but we'll talk about specifically its association with RNA polymerase 3. Alrighty, take it away.
All right, so because we're still on the topic of scleroderma and, I'm almost a nephrologist, so we care about the kidney disease and associations with scleroderma. So I did want to make this distinction, and I wanted to include this chart specifically for the fellows to refer back to. But the two main renal diseases associated with types of scleroderma are going to be scleroderma renal crisis and ANCA-associated vasculitis. And the big differences, there's many differences here, but scleroderma renal crisis is more associated with the diffuse cutaneous, whereas ANCA-associated is more associated with the limited cutaneous. Usually it'll happen early and after diagnosis in scleroderma renal crisis, usually within the first 5 years of being diagnosed, whereas the limited cutaneous association with ANCA-associated vasculitis will happen later in the onset of disease. Urinary sediment can be completely bland. Sometimes you'll have some red blood cells or some blood in scleroderma renal crisis, whereas in ANCA-associated vasculitis, you will see red blood cell acid proteinuria. The autoantibodies, as Julia mentioned, anti-RNA polymerase 3, which we'll talk a little bit more about, has shown a strong association and is a risk factor for scleroderma renal crisis, whereas in the ANCA-associated vasculitis, we see MPO antibodies. The renal biopsy we'll talk about a little bit more a little later, and treatment we'll get into in a little bit as well. I'll let Julia talk about the epi of SRC.
Yes, alrighty. And so, scleroderma renal crisis itself was initially described as early as 1952 by Moore and Sheehan, and then about 5% of patients with scleroderma will go on to develop scleroderma renal crisis. There was an interesting association I found in the literature where typically scleroderma renal crisis is more often seen in the regions of the US and Australia, more so than in Europe and more so than in Asia. And then the prevalence of RNA pol3 actually matches that distribution, where the US and Australia outweigh Asia in terms of the prevalence of the RNA pol3. And then even though, and we'll talk about some of the treatments and the evolution of that, Marco will go into that, but even with our treatments that we have available now, the 5-year survival after an episode of scleroderma renal crisis still remains relatively low, around 50 to 65%. And then, it's a question of, is this an indicator of just the fact that this patient has severe scleroderma because there's more of an association with the diffuse phenotype, or are these the sequelae of renal insufficiency and some of the things that go along with that? And then, did you want to do this one, or I could do this one? Oh, yes. And so with the associated symptoms with scleroderma renal crisis, typically you're looking at a blood pressure of greater than 140/90. We can also see LV dysfunction, congestive heart failure, pericardial effusion, sometimes very large pericardial effusion can be seen. Going with the fact that often this is patient presents with malignant hypertension, you can also see the typical retinopathy that you can see with malignant hypertension with these flame-shaped hemorrhages, cotton wool exudates, papilledema, and then secondary TMA, as we saw with this particular patient. And the secondary TMA will actually occur in about 50% of patients. You'll see this consumptive thrombocytopenia, schistocytes, and microangiopathic hemolytic anemia. And then just a note about some special cases. You can also have normotensive scleroderma renal crisis, where you do have the microangiopathic hemolytic anemia. It's actually more prevalent in cases of normotensive, where we described that it's approximately 50% in all cases. It's actually two-thirds of cases of normotensive SRC. And normotensive SRC describes about 10% of cases of scleroderma renal crisis. And there's a slightly higher association with corticosteroid use with normotensive SRC. And unfortunately, this actually carries a slightly worse prognosis than if the patient were to have malignant hypertension. And then there's also SRC sine scleroderma, meaning without the skin changes. And oftentimes it's because scleroderma renal crisis can be a very early manifestation of disease. As Marco mentioned, it typically occurs within the first 5 years of scleroderma diagnosis. And ways that you can look for clues about scleroderma if you're not specifically seeing skin thickening would be if patient has Raynaud's, if they're having puffy fingers, if they're having any type of inflammatory arthritis or those tendon friction rubs we talked about. And then it's very likely that because it's more associated with the diffuse scleroderma, that within months you will actually see those changes of diffuse scleroderma that develop. And then specifically with pregnancy, if you have a patient that's pregnant, it can be difficult to distinguish between scleroderma renal crisis and preeclampsia. So in patients with scleroderma that do end up getting pregnant, it's always good to keep SRC in your on the differential as well as monitoring them for preeclampsia. And then depending on which citation you read, some will argue that scleroderma renal crisis or a history of such is actually a contraindication to pregnancy, but that is not universally agreed upon. And then the main treatment, as we will discuss for scleroderma renal crisis, is the use of ACE inhibitors, which is contraindicated in pregnancy itself, so that makes the situation more complicated.
Can I ask a question about that?
Yes.
So is it because if you've had it before, that there's a higher risk of it happening during a pregnancy? Or is it just because it's hard to distinguish from preeclampsia? Or like why would they say that?
I believe that there's the association with the higher risk of it recurring, but there's also just, the inability to use the ACE inhibitor and the almost a delay in diagnosis with the concern for preeclampsia being another feature. Yeah, okay. Biopsy, that's you, right? All right.
All right, so let's talk a little bit about now, when do we get a renal biopsy? Because sometimes patients don't present, they didn't read the book before coming into the hospital basically, so not everyone follows this typical presentation. And if there's any confusion or concern that you maybe have a differential, you're looking for the ANCA-associated vasculitis versus an SRC, maybe they're not presenting with the typical malignant hypertension. So if there's any unclear etiology, then maybe a renal biopsy would be indicated. Now, I want you to remember that in order to get a renal biopsy, the current recommendations are to have a person have their blood pressure less than 140/90 consistently for 24 hours because of the risk of bleeding. Obviously, in these patients that are presenting with a blood pressure of 190 over something, it would be very difficult to get a renal biopsy in these patients, and the risk of doing the renal biopsy outweighs the benefit of treating with an ACE inhibitor or something like that. They did describe in the literature that it's not necessary to make the diagnosis overall, but really not necessary if a patient with diffuse cutaneous scleroderma shows up to your clinic and they have new onset hypertension with rising creatinine and a bland UA. They call this triad. I polled a couple of the renal attendings. They told me they haven't seen this triad presentation of completely bland UA, but I don't know, have any of the rheumatologists in the room seen? You have? So it's a very rare disease to start with, and then this presentation of the triad is pretty rare, but it can happen, and that should clue you in that we should be aggressive with treatment and monitoring and probably send the patient to the hospital. But we'll talk about management a little bit later. Speaking of the renal pathology, so what we see in the renal pathology is going to be very similar to a malignant hypertension, and it's almost impossible to differentiate just on renal pathology the difference between a sclerodermal renal crisis and a malignant hypertension. So what we actually see in the renal biopsy, I'll kind of orient us here. So this is renal parenchyma, the cortex. What we're seeing here is a glomerulus. A normal glomerulus should have open capillary loops, have infolding, have an intact Bowman's space, and not have extra cells. And what we're seeing here in this glomerulus is the loss of the open capillary loops, kind of shrunken and loss of that infolding, and this is seen when the glomeruli are ischemic. These are tubules here. We look to see if there's any extra cells in the tubules or tubulitis, inflammation. We're not seeing any of that. Luckily, we don't always get this on a biopsy, but we do have a vessel in this biopsy, and what we could see here is kind of the starting formation of that onion skinning that's always described on malignant hypertension. And here's a second picture again, glomeruli that are pretty damaged, but here has two better vessels that we could see, and this clearly shows that onion skinning that we see. It's just layers of fibrous deposition here in the arteries. This is a little bit earlier in the disease course of the biopsy. It's saying that it's you get this mucoid accumulation and adventitial fibrosis, which the literature tries to describe that this is why we think initially that maybe there's no complement involved, and this is all a result of the hypertension, malignant hypertension cascade that's going on. So why do we think that people get this stuff? Why does this happen? Let's see if I can just move this. So I found this schematic online which shows kind of the accepted proposed mechanisms. I don't think it's still truly understood what happens that gets these people to develop this malignant hypertension and really bad renal disease, basically. But the accepted contributing factors right now is that we believe there is some sort of genetic predisposition where people could have this endothelin or receptor polymorphisms that may predispose them to disease. There are immune factors, which we'll talk about a little bit, about patients getting glucocorticoids prior to patients with scleroderma getting glucocorticoids, as it may contribute to the trigger, sclerodermal renal crisis. And then there's also possibly immune factors associated with an anti-RNA polymerase III immune activation. So what we think happens right now is that there is some sort of trigger that causes the vascular damage. And then this vascular damage leads to reduced renal blood flow. And anytime the kidneys see less blood, they ramp up the renin-angiotensin system, and the renin-angiotensin is continually ramped up. There's still reduced renal blood flow, it continues to go, and that's what we think turns into this cascade of sclerodermal renal crisis. They've looked at some of these things as far as renin release. They have shown that the juxtaglomerular apparatus is enlarged in some of these patients, but when they've done studies to look at actual renin levels, they're not always elevated, so not really a good marker to look for in patients. But the true pathophysiology, if you will, has not been truly defined.
Can you go back?
Yeah.
Sorry, where you mentioned the all three antibodies, where would those fit in?
Probably in the immune activation cascade here. That's what at least these authors were able to put together is they think it would be kind of on the right side of that schematic there.
Not to get into the weeds there, but they're like targeting the endothelial activation or some other feature?
They're just saying that this anti-RNA peak could cause some sort of vascular damage, basically.
I have a note about that later on in the presentation, Dr. Dean.
Okay. I'd be curious to see if that's normal intensive and how this with antibody negative or the predictive effect, but the anti-centromere antibodies maybe. Anyway, I'd be curious to see how that all fits. Anyway, sorry, go ahead.
No, that's okay. So, speaking of risk factors, I know I mentioned glucocorticoids and some other things, but they've done a lot of studies on scleroderma. Really, a lot of these studies were done in the 90s and 2000s, but they found some associations that we've said have a higher odds ratio or hazards ratio of developing scleroderma renal crisis in these patients. So, like we've stated already, that it usually happens within the first 5 years of disease onset. So early diffuse cutaneous systemic sclerosis poses a risk factor. Rapidly progressive skin thickening. Julia had mentioned the Rodnan score, and if you see that the skin thickening is rapidly progressive, that is a big risk factor for developing scleroderma renal crisis. The positive anti-polymerase III antibodies, anything that could cause reduced renal blood flow, they believe could trigger the cascade, the same cascade that I just showed, of vascular damage, reduced renal blood flow, activation of the renin-angiotensin system, so things like sepsis or infection or anything that could cause an AKI, really. Glucocorticoid use, there's a lot of data on the use of glucocorticoids prior to sclerodermal renal crisis in patients with scleroderma. The risk factor or dose can be a little bit controversial. The big studies showed in 1998 that a dose of 15 milligrams given within the first 6 months of diagnosis was a big risk factor. Odds ratio of about 8 times in patients that didn't use steroids. And then there was a more recent study that said even 7.5 milligrams of prednisone could predispose these patients or be a risk factor for sclerodermal renal crisis. And then the use of ACE inhibitors, which we'll talk a little bit more about. So this is still a bit of a controversial topic because no great randomized controlled trial has been done in these patients to look at the use of ACE inhibitors prior to the onset of hypertension. So there was a thought process, if we're using ACE inhibitors as treatment of disease, can we use ACE inhibitors as prophylaxis in people that have these risk factors with scleroderma, with diffuse scleroderma, and would this reduce the incidence of sclerodermal renal crisis? And what the studies have found so far is that the people that were on ACE inhibitors that had no indication for hypertension actually had an increased risk of having sclerodermal renal crisis. So people have posed the thought that an ACE inhibitor in these patients may be a risk factor to developing sclerodermal renal crisis. So that's why we usually prefer using a calcium channel blocker first. And if we think about calcium channel blockers, that's also what we use in Raynaud's syndrome. So it may help some of the Raynaud's features, control the blood pressure. But we try to avoid ACE inhibitors in patients with scleroderma if we can.
How about if they've had a renal crisis already?
I'll get into that, but yes, you do want to keep them on the ACE inhibitor after having a sclerodermal renal crisis.
Could you give a comment on the weight of evidence for that?
Yeah, so the weight of evidence, like I said, it's still controversial. So this was a lot of case series, case studies. Again, no randomized controlled trial. They did one retrospective trial, but I think I found maybe 5 papers. It's not an abundant source of evidence, basically.
It's a tricky recommendation. And we had a conference here some time ago where that recommendation led to somebody going into renal crisis without getting an ACE inhibitor because they were worried about an ACE inhibitor potentially being a risk factor. So I think it's very challenging to put that into actual clinical practice, but it's interesting.
Yeah, I would say in practice, we
wouldn't start it in someone who didn't have hypertension, but if
That's
they had,
exactly what the papers
yeah,
looked
but if they
at.
had hypertension, I would say most of us probably preferentially
And-
choose an ACE inhibitor.
So yeah, that's why I'm confused about your last sentence, the calcium channel blocker first. Is that just for the Raynaud's or for hypertension?
So this was one study that made this recommendation, the use of calcium channel blockers. If you look at the guidelines right now in someone that is developing hypertension and has rising serum creatinine, you start them on an ACE inhibitor as soon as possible. There is some thought of, if they don't have a rising serum creatinine, is this hypertension due to something else, and maybe use a calcium channel blocker. But again, the risk of getting worsening sclerodermal renal crisis is obviously there. So I think it's on a case-by-case basis. You can put all the patients in one bucket. And we'll talk about the early initiation of ACE inhibitors in a little bit with treatment of sclerodermal renal crisis. So I thought this was interesting. There's been a lot of studies on renal dysfunction, and can we look at renal dysfunction and see if any of these show a predictor for developing sclerodermal renal crisis? So there was this big study that looked at, in Canada, more than 400 patients with scleroderma, and they were followed for a median of 2 years. What they did, they looked at their GFR over time, and what they found was that the decline in GFR did not predispose these patients per se to having sclerodermal renal crisis. They found no correlation between the two. What they did find that if before the sclerodermal renal crisis happened, if their eGFR was less than 60% or 60 already, they had a 3-fold increase in mortality. So if they're starting off with already pretty bad kidney function, it's not gonna look good. They did these studies on this kind of lab metric that I've never really looked at, which is residual renal function reserve, renal function reserve, which is something that they do where they give the patient a ton of protein and they look at the capability of the kidney to respond to the protein, basically. It's supposed to be a measure of basically how good your kidneys work after an injury or an insult of like a protein load. So the RFR was reduced in people with scleroderma overall, but again, these people found no association with the predictive incidence of developing sclerodermal renal crisis. And then interestingly, they looked at renal vasculature resistance or resistance indices. And what they found was that the pathology, when they're actually seeing it on the scans, is very similar to the pathology that we see in Raynaud's in the extremities that could happen in the renal vasculature. And this may lead to some of this decreased GFR that we sometimes see in these patients, but no association with predicting sclerodermal renal crisis. Again, looked at proteinuria. They're seen in about a third of patients with scleroderma, maybe an indicator of renal and systemic vascular damage, and then isolated hypertension. This is kind of going back to what Dr. D was saying about, it's unclear if this is a comorbidity of scleroderma. Like, is this a result that scleroderma is causing this, or is it a disease of, or is it a manifestation of the true vasculopathy that's happening in the kidneys that we see that's similar to the Raynaud's phenomenon? So 2 large studies looked at this. Each study had greater than 500 patients. They looked at hypertension. They found no association with the prior hypertension leading to or predicting sclerodermal renal crisis incidence, which I found kind of interesting because we tell these patients to check their blood pressure and we have them check it frequently, and then when we see hypertension, we start monitoring them more closely. But I thought that was interesting that in this study, they didn't actually find an association with incidence of sclerodermal renal crisis. Let's go into now, how do we treat this disease? So this was an extremely deadly disease prior to the 1980s. Nephrologists had a very tough time figuring out how to treat these patients. We tried high-dose steroids. It did not lead to any mortality benefit. They would even try bilateral nephrectomies because we were really stumped in how to stop this progression of disease and how do we keep these patients alive, because if someone showed up with sclerodermal renal crisis before the 1980s, they would die. I mean, the mortality was greater than 90%. In the late 70s and 80s, some reports started coming out that aggressive management of blood pressure led to better outcome of these patients. And they noticed that patients that were treated with ACE inhibitors for some reason had better outcomes. So then in the late, I think the first study was 1979, and through 1983, there was 3 landmark trials that came out, one by Lara, one by Clements, and one by Steen, that all showed that the use of angiotensin-converting enzyme inhibitors decreased mortality in patients with sclerodermal renal crisis. And what we've kind of, 2 of the studies looked at captopril, one just mentioned ACE inhibitors basically, but we've had a trend towards captopril because it's very fast acting and it's easy to titrate. And after the addition of ACE inhibitors into the treatment and making it the mainstay of treatment, the mortality decreased from 90% to about 30%. So I think if we could find the drug for these diseases that make your mortality go from 90% to 30%, that's really good. Yeah, right? I mean, 9 out of 10 patients dying versus 3 out of 10. That's a pretty good job just for the addition of one medication. So what do we do today when we get a patient that we think has sclerodermal renal crisis? How do we treat it? So again, the recommendation is quick administration of angiotensin-converting enzymes as rapidly as possible to bring a blood pressure back to 130/90 or back to baseline within 72 hours. Like I said, captopril is the mainstay of choice. Because there's 2 classifications, even though it's a very rare presentation, to have normal tensive sclerodermal renal crisis, if the patient has hypertension, you want to hit them with captopril and you want to up-titrate fast. So the starting dose, this is the recommendations right now, is anywhere between 6.25 to 12.5, and you can titrate up by 12.5 to 25 as fast as every 4 to 8 hours in these patients if you're not achieving the goal blood pressure. And the max dose, I wanted to reiterate this, especially for the renal fellows, because we get asked this a lot. At least in this patient, I got asked multiple times a day, what's the max dose of captopril that we can give? The max dose is actually 450 milligrams a day, and that could be divided into 6 or 3 doses, basically. If they do not have hypertension, the recommendation is still to start an ACE inhibitor. Obviously, you're going to start it very low with the 6.25 milligrams, and if tolerated, you do want to increase to the 12.5, but this depends on how their blood pressure is responding to the ACE inhibitor. Once you have had an episode of sclerodermal renal crisis, you should continue an ACE inhibitor indefinitely, like what Peter was asking. So these people, once they have the incidence, the recommendations right now are to continue the ACE inhibitor indefinitely unless they develop some contraindication to ACE inhibitor.
Is there any data on the ARBs?
So that's a great question. I tried to look into this. The 3 landmark trials that were done in the 80s and 90s, or 70s and 80s, only included angiotensin-converting enzymes. There have been some reports of ARBs in people that had a contraindication to ACE inhibitor, and it seems to work, but the basis of data is not robust, okay? And that's always a good question, because you think if this is an activation of the renin-angiotensin system, then why can't we use an ARB?
Sorry, I stepped out, I missed something. Were you gonna talk about this case that got something different from the get-go for their blood pressure management? Right, did they get?
So they
right off?
They initially presented to an outside hospital, so what they got when they hit the door, initially was started on that nicardipine drip. Because they weren't really sure of what was going on in the patient, but they were started on captopril pretty early in the disease course. I think it wasn't even 24 hours before he was started. So he was still initiated on captopril very early in the disease course.
Yeah, you knew you were gonna talk about this, but do you wanna speak to that? What's the emergent approach? Is it still captopril or is there some other approach?
Oh, it's captopril. Yeah, it's early.
No matter what, this guy, acute thing, you wouldn't use IV therapy, you just start with captopril.
There's the keyboard.
Okay. So there is some recommendation for IV therapy other than captopril. They say if a patient presents with hypertension and has some CNS involvement, they still want the captopril on. You start the captopril fast, but you have some IV backup therapy to try and bring down the blood pressure as well, because there is CNS involvement. And then the thought or treatment course of that would be that you reduce the IV therapy as fast as possible while up-titrating the captopro. And the mainstay of treatment still is an ACE inhibitor. But there is some exciting data coming out on possible future therapies. Like I said earlier, endothelin receptor polymorphisms may play a role in genetic predisposition to developing sclerodermal renal crisis in these patients. We know from biopsies that have been stained that endothelin-1 is overexpressed in renal biopsies from sclerodermal renal patients. And endothelin receptor antagonists are used in some of these patients for pulmonary arterial hypertension and digital ulcers. So there have been some case studies adding endothelin receptor antagonists like bosentan onto the ACE inhibitor, and they didn't find any severe adverse reactions in those cases, and it seems to be well tolerated. It was a small case series of 6 patients, and hypertension recurred in 3 patients with the bosentan when the bosentan was stopped. So maybe confers some sort of additional benefit, but no large studies have looked at this to prove that yet. And then the use of C5 inhibitors is something that's on the rise now. It's been limited to just 2 studies. They used eculizumab in very refractory disease where they couldn't control the blood pressure and they had very severe TMA. It's shown some benefit. This was only 2 case series though, so very, very limited data of evidence. And eculizumab has its own risk involved with it, with severe immune suppression and the cost of the medication really. So if we don't have a clear benefit to the use of this medication, then I guess we'll see what the data shows, but we'll see as people use it in case series and case studies. Julia wanted to mention a note about complement here.
Marco definitely summarized the fact that we don't have very much data about the complement inhibitors, and many times it's used to target sort of the refractory TMA component of sclerodermal renal crisis. But just a couple of things, there is some growing evidence for the role of complement in general within TMA syndromes. And outside of atypical HUS, which is associated with complement consumption. And so they have found that there are complement mutations found in patients that eventually get in any type of TMA. So this is talking about HUS, TTP, obviously atypical HUS. And then there have been cases of TTP HUS and atypical HUS described in association with scleroderma renal crisis. So these kind of happen concurrently, and those were the explanations for the TMA that happened. And then there was a gene screening study of the RNA pol3 patients that developed scleroderma renal crisis, and there was a strong association with dysfunction within the complement system in patients with RNA pol3 that ended up developing SRC. And kind of lastly, there have been C4d deposits, which is a kind of a byproduct of the classical complement pathway that were demonstrated in renal biopsies of patients with SRC, and they were typically associated with some of the worst outcomes. So, we're still waiting on additional information, additional studies, more information on the efficacy of eculizumab, but just a thought.
Great. Thank you. So this is an area of interest of mine, so I figured I would mention it here just briefly. Unfortunately, fortunately that we've had ACE inhibitors be introduced into the mainstay of treatment of these patients, but unfortunately, 40 to 50% of people, about 50% of people do not have renal recovery and stay on dialysis, which is not fun. We try to keep people off of dialysis, right? So what's interesting though is that in other forms of AKI, we usually give them about 3 months before saying we don't expect any recovery. But specifically in sclerodermal renal crisis, the recovery time could take a lot longer. So there was 2 large case series studies that showed a recovery median of 8 months in one study with a range from 3 to 18 months, and 11 months in the other study, which showed 1 to 34 months, which is pretty impressive that almost 3 years later, someone's coming off of dialysis after they've been on for almost 3 years. So right now, the current recommendations is to delay transplantation of the kidney from to 18 to 24 months if there's any evidence of renal function recovery while on dialysis. So you're seeing their renal reserve or their renal KT over V start going up, they're needing less dialysis, wait 18 to 24 months before reverting them to transplantation. And then if they've been on dialysis for 12 months, you've seen absolutely no incidence of renal recovery or signs of renal recovery, you could go ahead and refer them for transplantation. Interestingly, recurrence rates are low. This is from the UNOS data. From 1987 to 2004, only 260 people with sclerodermal renal crisis were transplanted. So you can see that's a very rare disease and even rarer to get transplanted after. But the recurrence rate during that time period was only 1.9%, so pretty low. And again, data sparse, but getting a transplant is better than being on dialysis 3 times a week. So it does improve quality of life. There's some argument that CNIs may increase the risk of sclerodermal renal crisis, and obviously we use CNIs in people after transplantation, but the recurrence rates are pretty low, at least from 87 to 2004.
Alrighty, yeah. So would love to kind of show you guys the clinical course of the patient we were initially discussing. So this is on this left, Dr. Dean has emphasized not using specific dates because that is, patient protected information. So this was day 0 when he came to the university, and then 2 weeks later, this is sort of the progression of his creatinine, so kind of up and down during his hospital course. However, he's seen in clinic 1.5 months after presentation, and his creatinine has improved greatly, and then continues to improve 4 months later with the great care of Dr. Marcy as his primary rheumatologist. And then this patient was discharged on an ACE inhibitor, lisinopril 40 milligrams and amlodipine for his long-term treatment. And then even though he did have this sclerodactyly, it was felt that his skin disease was stable, thus he is not currently on immunosuppressive therapy. And just for reference, with that top number, his GFR at the 4-month mark was 67. Okay, and then this is just showing the progression of some of his other markers of disease and this thrombotic microangiopathy. So again, day 0, 4 months later. So he came in with this hyperbilirubinemia indicating TMA. It resolved inpatient relatively quickly. And then his LDH came down progressively. The haptoglobin was detectable within about 10 days or so. And then hemoglobin did show recovery over time. Platelets came up as well during the admission. Schistocytes still visible at the end of his admission. But I imagine that with the rest of these markers, there's no need to check the schistocytes again. And just some take-home points to summarize our presentation. So in patients with these high-risk features, we should be monitoring blood pressure at home. If you have a scleroderma patient with new hypertension and it's greater than 140/90, repeat in 1 hour, make sure that they're doing all of the correct things of measuring their blood pressure, and then let their doctor know, get labs, get a urinalysis, figure out whether or not this is an early presentation of scleroderma renal crisis, and then limiting corticosteroid use. As Marco mentioned, some of the more recent data suggesting less than 7.5 milligrams of prednisone or the equivalent, and some of the older data was less than 15. I think we do a great job of trying to avoid prednisone use in general with our scleroderma patients within the rheumatology clinic, but just a thought. And then first-line treatment with is early detection of the scleroderma renal crisis and rapid initiation of the ACE inhibitor. And then there are these new potential treatments with the endothelin-1 receptor antagonists and possibly eculizumab and complement inhibitors. And again, even though we've gotten better at in-hospital mortality, decreased from 90 to 30%, still the 5-year survival following a scleroderma renal crisis is still around 50 to 60%, and that hasn't changed very much since this change in treatment paradigm earlier on. And those are our references, and Marco highlighted this one, it's a very good renal review by Woodworth.
For the renal fellows, if they want to look at that Nature review, it has a lot of good cases in there.
And then, thank you all so much for your attention. Yes, Dr. Zhang.
So just a pathology question. So when you're looking at the path of scleroderma renal crisis, how is that different from what you might see in just a TMA? Like, I'm just trying to like in my head sort out like TMA versus, because we think TMA is playing a role in a lot of these cases, but like is the onion skinning more unique to scleroderma?
You could actually see in some TMA cases like actual schistocytes on the biopsy and stuff like that that you may not see in malignant hypertension or something, but if the MAHA is present, then you may also see it on those patients. So it's very difficult to differentiate between the two.
So it looks really similar.
So, there's two, like when TMA, there's two TMAs on biopsy. One is glomerular TMA and one is vascular or arterial TMA.
Okay.
And so the HUS TTP falls in the glomerular TMA category versus malignant hypertension scleroderma falls in the arterial TMA category.
Okay.
So technically, they should be completely different,
Okay.
but it's not a black-and-white distinction.
Okay.
But malignant hypertension and scleroderma renal crisis, there's no difference.
You just can't tell the difference, yeah.
There's no
Okay.
difference.
That's very helpful.
Vascular injuries that, Jason?
Is there any utility in like repeating the RNA polymerase antibody? Like, do you follow it at all, or is like positive once and then you just know it's positive?
That's a great question, and the same way that we generally don't repeat ANAs unless there's a very specific reason to, we typically don't repeat antibodies unless there's a very questionable diagnosis. In the case of a patient that has a positive RNA pol3, does have scleroderma renal crisis, they very likely have a true positive RNA pol3, and the level doesn't really affect how severe their presentation is going to be.
It's not a disease activity measure, so and it doesn't tend to go away unless you do CAR T.
Good point. Yes, Dan?
After someone gets a renal transplant, would you continue them on their ACE inhibitor?
That's a great question, and there's been some debate about this. There's no great data on it right now. I probably would, because they had something like that, but like I said, this is just, personal preference, basically. There really is no great data after getting the transplant on whether continuing ACE inhibitor, unless you know some data, Dr. Dulesky, on,
No, and I would say, the transplanters here would take them off.
Yeah. At least for the first 6 months, 9 months after, and then they would restart it maybe. But you'd think if they could come off of it for a transplant and do all that, that you'd start the pregnancy thing, if they're stable, could you stop it? Because you could restart it right when they're breastfeeding, restart an Allopril at least. So maybe, it's so rare that you'd hate if,
Exactly, that's the main issue with this disease, is that our N is very small in all these.
Yeah. But we'll probably get one now.
Yeah.
Now that we've talked to us and bring this up, and we'll be like, what do we do?
We did have a run of three patients within 3 months that we had that was scleroderma renal crisis here, so, they come in batches.
How does when you look at that 5-year survival of 65%, how does that compare to advanced renal disease of any etiology? Is that a lot higher?
No.
Right.
50% die within 3 to 5 years, so, and that's what I was gonna ask, has it changed with more advanced, and I don't know if they've looked at that, is it really the people that remain on dialysis? Is it the people that couldn't stay on an ACE at high doses because of hyperkalemia that now isn't as big of an issue? I don't know.
The most recent studies were I think early 2000s, so I don't know if someone's looked at it again since then, or at least I couldn't find anything that was more recent.
All-cause mortality too, right?
It is all-cause
Those,
mortality.
having SRC is a really poor prognostic factor overall, RNA pol-3 is associated with cancer. So they can die from cancer or ILD or PH or cardiac disease.
Because then they have end-stage disease, and then they have cardiovascular events.
Yeah, but it seems like it shouldn't be, it's rare, so maybe it'd be hard to
Maybe
study,
that's
but
not- yeah.
it would be nice to know, is it just because they have higher rates of ILD, or is scleroderma renal crisis actually a systemic process, you know what I mean, that affects other areas of the body, and we're focused, because I mean, you would think if acute disease with ACE inhibitors is better, how can we attribute the same mortality to renal disease? It seems like it has to be something else.
Yeah, when they look at the mortality studies, it looks more like ILD, PH, or